Welcome to Easy Endo Prep's Endo in a Bite. I'm Dr. Sumbul Beg, and this podcast is your quick study snack designed for busy endocrinologists who want fast, board-relevant content that actually sticks. Whether you are preparing for initial certification, recertifying, completing the LKA, or simply staying sharp in clinic, this podcast is built for you. If you want my full board-focused system, visit easendoprep.com, where you can enroll in the complete Easy Endo Prep Board Review course or start a free trial. Today we will discuss measuring vitamin D and replacing vitamin D. How do we approach this? Well, it helps to understand that physicians have been practicing under 3 different frameworks when thinking about vitamin D. These frameworks come from different periods in medicine, and each one shaped how clinicians think about testing and treatment. The first framework comes from the Institute of Medicine, now called the National Academy of Medicine. Their work focused mainly on bone health and population nutrition. Their conclusion was fairly simple. Most healthy people can maintain adequate vitamin D levels if they simply meet the recommended daily intake. For adults between 19 and 70 years old, that intake is about 600 international units per day. For adults older than 70, it increases to about 800 international units per day. Pregnancy and lactation also use about 600 international units daily. The Institute of Medicine approach assumes that if a patient is meeting the recommended daily intake, most of the time their vitamin D status will be adequate. So the focus is not on checking blood levels. The focus is simply on making sure patients are getting enough vitamin D through diet or supplements. Vitamin D supplements typically come in 2 forms. Cholecalciferol, also called vitamin D3, is the form produced in human skin after ultraviolet exposure and is commonly used in supplements. Ergocalciferol, called vitamin D2, comes from plant and fungal sources. Both forms can be used for supplementation, so the first framework was really about intake, make sure patients get enough vitamin D each day, and in most healthy individuals that is sufficient. But then a second framework emerged. In 2011, the Endocrine Society published a clinical practice guideline that took a much more laboratory-focused approach. This guideline emphasized measuring the 25-hydroxyvitamin D level and treating patients based on those numbers. Because of this framework, many clinicians began checking vitamin D levels routinely and treating aggressively when levels were lower than expected. And this drove a major increase in vitamin D testing over the past decade. But then the field shifted again. In 2024, the Endocrine Society released a new clinical practice guideline focused on vitamin D for prevention of disease. After reviewing randomized clinical trials, the panel concluded something important. No clear vitamin D blood level has been proven to improve outcomes in generally healthy individuals. So what does that mean clinically? It means the new guideline moves away from chasing specific laboratory numbers. Instead, it returns to focusing on adequate intake. For most healthy people, routine vitamin D testing is not recommended. Instead, the emphasis is simply on making sure patients are getting appropriate vitamin D intake. Now, the guideline does identify several groups where empiric supplementation can be helpful. First, children and adolescents between 1 and 18 years old. In this group, vitamin D supplementation can help prevent nutritional rickets and may also lower the risk of respiratory infections. Across the trials reviewed by the guideline, the weighted average dose was about 1,200 international units per day. Next, adults younger than 50. For most healthy adults in this group, additional supplementation beyond the usual dietary intake is not recommended. The key point is simply to meet the daily intake target, which is about 600 international units per day. Adults between 50 and 74 are treated similarly. Again, the emphasis is on meeting the usual daily intake rather than routinely adding extra supplementation. But there is one age group where supplementation becomes more relevant: adults 75 years and older. In this group, vitamin D supplementation may reduce mortality based on randomized trial data. Across the studies reviewed, the weighted average dose was about 900 international units per day. Pregnancy is another group where supplementation may be beneficial. Vitamin D supplementation during pregnancy has been associated with reductions in complications such as preeclampsia, preterm birth, and other adverse outcomes. The weighted average dose across trials was about 2,500 international units per day. Another population to remember is adults with high-risk prediabetes. In addition to lifestyle modification, vitamin D supplementation may reduce the risk of progression to diabetes. Across trials, the weighted average dose was about 3,500 international units per day. Now, there is another practical point. When supplementation is needed in adults over 50, the guideline favors daily dosing rather than large intermittent high-dose regimens. And one more clinical pearl. Measuring 1,25-dihydroxyvitamin D is not helpful when evaluating vitamin D stores. This active metabolite can actually appear normal or elevated even when overall vitamin D stores are low, so it does not reflect total vitamin D status. Large randomized trials also influenced this shift in thinking. One of the most important was the VITAL trial. In that study, more than 25,000 participants received vitamin D3 supplementation or placebo. The trial looked at major outcomes such as cancer, cardiovascular disease, and fractures. Vitamin D supplementation did not reduce these outcomes in generally healthy adults. So how do we apply all of this in practice? It helps to remember the three historical frameworks. The Institute of Medicine focused on intake, the 2011 guideline focused on blood levels, and the 2024 guideline returns to focusing on intake again. Let me close with a few key numbers from the 2024 Endocrine Society guideline that are helpful to remember in clinical practice. For children and adolescents between 1 and 18 years old, roughly the number to remember is about 1,200 international units per day. For adults younger than 50, the recommendation is simply to meet the dietary reference intake, which is about 600 international units per day. For adults age 50 to 70, the target remains about 600 international units per day. For adults age 71 to 74, the recommended intake increases to about 800 international units per day. For adults 75 and older, empirical supplementation is suggested, and roughly the number to remember is about 900 international units per day. For pregnant individuals, the number to remember is about 2,500 international units per day. And for adults with high-risk prediabetes, the approximate number to remember is about 3,500 international units per day. So the quick way to remember this is simple. 1,200 for children and adolescents, 600 for adults under 70, 800 for adults 71 to 74, 900 for adults 75 and older, 2,500 during pregnancy, and 3,500 for high-risk prediabetes. That wraps up this episode. Inspo for this episode was taken from ESAP 2026. These were the points that were mentioned, and I found them clinically relevant. If you missed anything, don't worry. I've taken all the notes for you. You can get a clean summary with headings and bullets delivered straight to your inbox. Just head over to www.easyendoprep.com and sign up for the newsletter. Keep tuning in. I release a podcast every Monday, and let's continue to learn one bite at a time.